Hello, everyone, and welcome to this week's lecture of No Neuropsychology. My name is Lizzie Stewart, and we are pleased that you all could join us for this week's lecture in Volume 10 of our No Neuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to our new content. New to No Neuropsychology is our collaboration with APPCN to bring you learning and discussion questions that are provided with specific lecture content. You can access these on our website or through APPCN. Here are the disclaimers for our series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box in the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Donald Bearden and Dr. Molly Winston for today's lecture entitled Functional Mapping in Epilepsy Using Different Methodologies. Dr. Donald Bearden is a board-certified clinical neuropsychologist at Children's Healthcare of Atlanta and assistant professor in the Department of Neurology at Emory University School of Medicine. His research and clinical focus includes pediatric epilepsy, epilepsy surgery, and functional mapping using SEEG. Dr. Molly Winston began a position as a pediatric neuropsychologist at Children's Healthcare of Atlanta and assistant professor in the Department of Neurology at Emory University School of Medicine before completing her postdoctoral fellowship. Her clinical interests include pediatric epilepsy, congenital heart disease, neurodevelopmental disorders, and general outpatient neuropsychology more broadly. Please join me in welcoming Dr. Donald Bearden and Dr. Molly Winston.
Hi, everyone. Thank you for being here today. We're happy to talk to you about functional mapping in epilepsy using different methodologies. And I will let Dr. Winston set up the PowerPoint.
To share our screen.
All right.
Hopefully everybody can see just our screen and not our notes, right?
I'm going to get there. How do I? There's that one. Okay. All right. Minimize that. There we go. Okay, perfect. So as far as disclosures go, I have 2 grants funding me currently, but neither one has anything to do with today's presentation, and Dr. Winston has nothing to disclose. Here's an outline about today's presentation. I'll give you a brief history of stereo EEG and how electrocortical stimulation works. And then Dr. Winston will pick up with a case example discussing the demographics, pre-surgical workup, and outcomes. It's important to mention that although there are multiple methods for functional mapping, including fMRI, for example, MEG, today's talk focuses on SEEG for functional mapping. With that said, I'll move into an overview of SEEG, which also goes by the name of stereo electroencephalography, stereo EEG, and SEEG, depending on where you're located, where you trained. Before I dive into SEEG's history, I want to provide some context to get us started. I won't assume that anyone attending has heard of SEEG or knows when and why it's used. SEEG is a minimally invasive surgical procedure that uses advanced technology to implant electrodes in the brain through small holes in the skull in order to identify where seizures start. SEEG is ideal for complex epilepsy cases because it provides a 3D view of the brain to better understand where depth electrodes are in relation to each other and in relation to brain structures and seizure activity. So why is it useful? It's estimated that about 1% of people in the US have active epilepsy. That means they're continuing to have seizures or they need treatments for seizures. And the estimated proportion of the general population with active epilepsy is thought to be between 4 and 10 people per 1,000. And globally, an estimated 5 million people are diagnosed with epilepsy each year. And approximately 30% of people with epilepsy develop drug-resistant epilepsy, which is defined as the failure of adequate trials of 2 tolerated, appropriately chosen, and used anti-seizure medications. For patients with drug-resistant epilepsy, an initial workup may be done to evaluate their candidacy for epilepsy surgery. What makes a good epilepsy surgical candidate? Well, a few things. So concordance among imaging findings and EEG findings is one. For example, MRI findings of a discrete temporal lobe lesion and concordant video EEG monitoring findings of seizure zone in that region. In addition, the seizure has to be reachable using surgical techniques and not in an area where it would require destruction of eloquent cortex important for daily functioning like language. So the initial epilepsy surgical workup, which we call phase 1, which is generally non-invasive, is done and includes prolonged scalp, video EEG monitoring, structural neuroimaging, and neuropsychological assessment. PET, SPECT, MEG, and high-density EEGs may also be done. This will vary based on the individual patient's needs. And we also do functional MRI during phase 1, which is used to complement intracranial functional mapping using stereo EEG. Not for every patient, but for those when it's indicated. If during phase 1 we find inconclusive brain MRI, discordant findings among the data we've collected, or overlap of epileptogenic zone and eloquent cortex, a phase 2 investigation may be done. And this can include electrocorticography, subdural electrodes, or SEEG. Now, at our institute, we no longer use subdural electrodes and use SEEG instead. If a phase 2 is necessary, the patient is admitted and depth electrodes are implanted, which at Children's happens on Tuesday mornings. And patients are then monitored for seizure activity. No mapping is done within the first 24 hours of implantation due to increased irritability of the brain. And then if the patient hasn't had seizures by that time, we typically begin weaning them from their anti-seizure medication in the hope of increasing seizure activity. And then we wait until we capture at least one habitual seizure, but generally we want more than that, or actually we always want more than that. It just depends on the patient. And after we get enough seizures, then we'll restart the anti-seizure medication and do the mapping at that point. SEEG involves the implantation of electrodes through small holes in the skull. Electrodes are typically 0.8 millimeters in diameter and fit through holes in the skull, which are about the width of a piece of spaghetti. An implantation is done under general anesthesia and can take 1 to 2 hours. And we typically implant less than 20 electrodes in a single patient. And after implantation, the electrodes may be somewhat irritating to the patient, but thankfully they're not painful usually. So next, I'll discuss SEEG's history briefly. SEEG was first developed by Jean Talairach and Jean Bancaud between 1957 and the early 1970s at Hospital St. Anne in Paris to gather spatial and temporal data on seizure activity in order to localize and lateralize epileptogenic zone. And you can see Talairach here smoking a cigarette looking very French with a stereotactic frame around his head, obviously not with the electrodes inserted. And in the early days of SEEG, this type of frame was used to place the electrodes. As I mentioned earlier, SEEG involves implanting depth electrodes through small drill holes in the skull to stereotactically define coordinates in the brain. Now, there are some examples of the evolution of the stereotactic system for implantation of electrodes presented here. The image on the left shows the stereotactic halo, and the image on the right shows the frameless system with bilateral mechanical arms. Now, here are some other examples. This depicts, so the far left, upper left-hand corner depicts the burr hole mounted frame, which rotated around the center of the burr hole to aim it at the target. And then next to that B, this was called a translational frame because it translated along different axes to aim it at the target. And then the lower left corner, C, this one includes a system of interlocking arcs using preoperative images. Computer software then calculated the angles necessary for correct positioning of the instrument. The last one is referred to as the arc radius system. After lining up the center of the arc with the target point, full insertion of the instrument would deliver its tip at the target point, regardless of the point of entry. And then on the right, we show a diagram or diagrams that were done largely by hand to avoid vascular structures during insertion. Diagramming trajectories initially involved a combination of angiography and ventriculography within the talarac space. And then this would eventually be replaced by co-registering CT and MRI, which improved visualization and planning. For talarac space, for anyone who doesn't know, is a three-dimensional coordinate system of the human brain used to map the location of brain structures independent from individual differences in the size and overall shape of the brain. And now SEEG has been used in France and Italy for over half a century for identifying seizure onset zone. However, this technique only recently caught on in North America. So the question is why? Well, it's probably due to a lack of familiarity with the procedure and how to analyze the data it produces. In addition, prior to the more recent technology, the procedure required manual adjustment of stereotactic coordinates for each electrode, which made it technically laborious and time-consuming. You can think back to the older ways of doing SEEG, of inserting those electrodes that I showed you a few minutes ago. So you can see how tedious that would have been. There are also the need for cerebral angiography to avoid cerebral vasculature, which was further time-consuming. It's only in the last decade or so, with the application of stereotactic robotic assistance and increased safety without the need for catheter-based angiography, that SEEG has become more widely used. And as you see from these images, the robotic stereotactic technology allows for quick navigation from one trajectory to the next with a high degree of accuracy and reliability. As I mentioned earlier, the procedure typically takes about 1 to 2 hours now. This robotic arm reduces the manual burden on the surgeon and the time to set trajectories, which allows for increased numbers of electrodes in more complex arrays. It also has the capability to avoid blood vessel injury and hemorrhage without the need for invasive angiography. Its software can be combined with combination of T1 weighted MRI to allow the surgeon to visualize and manipulate trajectories and anatomy in a three-dimensional space. Prior to SEEG making its way to North America, subdural electrode recording was the preferred method for intracranial mapping for decades. Some of you may have heard of it. But with the advent of the robotic arm, SEEG has become the preferred method. It doesn't require craniotomy. It's better tolerated, and in some cases, it's been associated with better seizure outcome, although more research is needed in that area. One of the most important differences between subdural grids and SEEG include the location and density of areas tested and the stimulation parameters. A strength of subdural electrodes is that they provide dense coverage of the cortical surface, but without access to the deeper structures, whereas SEEG provides sparse coverage of the lateral cortex while allowing access to those deep targets. You can see on the left that subdural electrodes versus the right, where you see the electrodes implanted. Now, I'll speak on how electrocortical stimulation works using stereo EEG. As you're aware, I'm neither a neurologist nor a neurophysicist, neither is Dr. Winston. So we're presenting information that was provided to us by our amazing team of neurologists at Children's Healthcare of Atlanta. An important caveat here is that use of SEEG for functional mapping is not standardized, which means the procedure may vary from institute to institute. So if you've been exposed to SEEG at another site, this may be information that's somewhat different, but that's okay because it's not standardized. We here at Children's created a video to help patients and families understand SEEG, the SEEG procedure, and it provides some of the information seen in the earlier, or some of the information that I've discussed earlier about the robotic arm. So I'll show that now, and we should have that ready to go. Oh, sorry. I don't know where it is. I'm gonna let you find it.
Okay. Okay, can everybody see a video, hopefully? Great.
Yes, looks good.
And the volume restoration.
Oh, no. Back.
To find out where the seizures are happening in the brain, a pediatric neurosurgeon may perform a procedure called stereo.
Can people hear the video?
Yes, we can hear it.
Okay,
Right.
amazing. Thank you.
Electroencephalography, stereo EEG, or SEEG. A robot will be used to insert electrodes into the brain to help find where the seizures are happening. To begin, the surgeon will secure the patient to make sure everything is aligned with the robot. Then the patient is connected to the robot. Next, the robot will move to the precise spot to place the first electrode. Using the robot arm as a guide, the surgeon will make a tiny hole in the skull. Then an anchor will be placed in the hole. This process will be repeated until all the holes are made. Next, the surgeon will carefully pass an electrode through each hole into a precise spot in the brain. Each electrode will be tested for quality of recording brain waves. To end the procedure, the surgeon will remove the robot and securing device from the patient, but the electrodes will remain in place. The head will be wrapped with a bandage. After the procedure, the child will stay in the hospital connected to a video EEG. Over the next 3 to 10 days, the seizure activity in the brain will be monitored 24 hours a day. During this time, a pediatric epileptologist will work with the neurosurgeon to find the location of the seizure activity in the brain using signals from the electrodes. Once the recording is completed, the electrodes will be removed from the brain. This procedure takes 15 to 30 minutes in the operating room under general anesthesia. Based on the findings, a plan of action will be developed. This plan may include surgery to remove the affected part of the brain, stereotactic laser therapy, depending on the location and size of the affected area, or non-surgical treatment options. The doctor will help you understand the options for your child. Contact our epilepsy team with any questions you have about your child's.
All right, we're just getting the presentation back. Okay.
Okay, awesome. Thank you. Awesome. Thank you. So now that you've seen how the electrodes are implanted, once they're placed, we do a post-surgery CT and then co-register that with the pre-implantation MRI to determine the exact electrode path for each electrode, which is then used to make a map that guides selection of our functional mapping tasks, dependent on what part of the brain the electrodes are going through. And then some information on electrodes. They typically have 10 segments spaced out in millimeters, where stimulation can occur along the path of the electrode, and stimulation can happen in pairs of segments. So 1 and 2, 3 and 4. The length of depth electrodes can be different depending on which brain regions are targeted. So depending on how deep you're needing that electrode to be. And then regarding the orientation of the electrodes following implantation, one end of the electrode is most mesial or innermost, and then one is most lateral or outermost. So conceptually, this means that we're looking at each electrode across a path in the brain three-dimensionally, which may include varying regions of cortex along different parts of the electrode. One electrode may be going through the hippocampus. Another part of that electrode then enters the mesial temporal cortex and then onto the lateral temporal cortex. Here I provide some definitions of terms I hear a lot in the context, or we hear a lot in the context of SEEG, which may be helpful to you. So the pulse width is a measure of the elapsed time between the leading and trailing edges of a single pulse of energy. And in SEEG, it remains constant across areas of stimulation. Frequency, which is measured in hertz cycles per second. In the context of SEEG, this refers to the frequency at which pulses of current are delivered. So at Children's, we do both low frequency and high frequency mapping. Some institutions may not do both, so I'll go into more detail about how they differ in a moment. And then you see current, which is measured in milliamps, and this is the power of the current delivered through the pulses. And lastly, train duration, which is measured in seconds. And this is how long the pulses are being delivered. So longer duration for low frequency and shorter duration for high frequency. But I'll talk about that in a sec. So this is how we conduct low frequency mapping at our institute. 1 hertz pulses, 15-second train. We deliver the pulses of current from 1 to 5 milliamps over 15 seconds at a frequency of 1 hertz. And the goal of low frequency mapping is to perform functional mapping by looking for deficits with stimulating and to assess connectivity of different cortical regions. Now, in comparison, for high frequency mapping, we do 50 hertz pulses, a 5-second train, deliver pulses over current at 1, 3, and 5 milliamps over 5 seconds. And so the goal of high frequency mapping is to potentially stimulate a typical seizure. Technical difficulty, sorry. There we go. So during the procedure, I'm typically, Dr. Winston or I are typically on the side of the patient's bed opposite of the EEG monitor and computer, and the epileptologist and the neurophysiology technologist are on the side of the bed with the monitor, which is also where the stimulation technology is. And then we have a stool where I conduct or Dr. Winston conducts testing with the patient, and we're typically accompanied by at least 1 trainee for note-taking and assistance. And prior to stimulation, the epileptologist will let us know the electrode and current strength. So for example, they may say something like, 5 milliamps at 2 and 3. And then the neurophysiology technologist will say start or stop out loud to indicate when the stimulation begins and ends. This is very helpful for us to know because we can't always see exactly what they're doing. We typically do low frequency first, followed by high frequency, which may occur in different mapping sessions over the course of days, depending on the patient. Just depends on the patient's bandwidth. And during mapping, we, meaning neuropsychology, take notes about clinical observations, and that can include task disruptions, sensations reported by the patients, in addition to electrographic changes, which is information we get from our epileptology colleagues across the bed. And this includes information on CCEPs also, which are important, also known as cortical evoked potentials, and after discharges. So CCEPs and after discharges. CCEPs provide information on connectivity. For instance, if we're stimulating electrode A at electrode segments 2 and 3, and we get CCEPs at electrode B, this indicates regions of A and B are interconnected. After discharges, in contrast, provide information on connectivity, but also irritable zones or areas that may be linked to the epileptogenic activity. The irritative zone is described as brain areas generating interictal epileptiform discharges or epileptiform discharges in between the seizures that we see. For instance, if we're stimulating electrode A at segments 2 and 3 and get after discharges at B, this may indicate that this area is more sensitive to seizure activity and can help to guide interventions. Now here, I provide a bit more explanation regarding CCEP. So during SEEG, connectivity is implied if an electrode's activity is changed by the stimulation of another electrode. CCEPs are probably the closest we can get to a measure of anatomical connectivity in the human brain. CCEPs have been used to examine connectivity between language areas and within the motor cortices. Data regarding CCEPs during SEEG mapping has led to sparing of white matter during epilepsy surgery in order to preserve connectivity between the different regions or different brain regions supporting a function. So, an example is sparing white matter connections between anterior and posterior dominant temporal lobe regions so that language won't be disturbed. As you can see from the images, I've put up some examples of CCEPs here, taken from Drain and colleagues' paper on SEEG from 2021. So you can see the far left, this is an axial MRI T1 of the brain showing two periventricular nodular heterotopias in the trigone of the left lateral ventricle and their trajectories of electrodes 7, 9, and 35. And then B shows the approximate lateral entry points of pertinent left-sided SEEG electrodes. And then F shows is the connectivity map for stimulation to electrodes 7 and 35. So what does it mean? If we're looking just at stimulation and you're looking at the ictal spread or the seizure spread, you can see that for electrode 33, it shows no spread. But if you look at the CCEPs, which tells us about networks that are interconnected, in fact, you do have CCEPs going from electrode 7 to 33. So that tells us that is potentially part of a node, a functional node, and may have surgical implications. There's a lot of research yet to be done on CCEPs. So with higher frequency stimulation, seizures are more likely and can cause after discharges, which is why we do low frequency mapping first. If we're doing low and high, we do low first in case we trigger a seizure with high frequency. After discharges tell us about connectivity, as I mentioned before, but they also tell us about the seizure onset zone and areas of irritability. After discharges can appear in the epileptogenic zone, but also in non-epileptogenic cortex. Duration and propagation patterns can help quantify the risk of stimulation seizures or a seizure due to stimulation. An important point of mapping is that the hippocampus is highly sensitive to after discharges, which can be problematic because it might trigger a seizure. However, a technique known as brief pulse stimulation is used, and it's a safe and effective way to stop after discharges from turning into seizures, especially if they're delivered quickly. That's the key, but they don't always work. So you can see here on figure 3 at the top, you see the first one is an example of rhythmic spike after discharges that were terminated by brief pulse stimulation applied at 8 seconds. Now, in contrast, you see in B, you have sequential spike after discharges that were refractory to brief pulse stimulation, but they weren't applied until 14 seconds. And then some types of spike wave activity is just more refractory. So with C, you see polyspike after discharges that are refractory to brief pulse stimulation. And lastly, D, you see spike wave after discharges that were more sensitive to brief pulse stimulation. So they worked. All right, now Dr. Winston will move into her case presentation that will hopefully congeal all the information I've just presented. Thank you.
Excuse our musical chairs. So I think Dr. Bearden provided a really nice background for all of us on SEEG and what it looks like. But to bring everything together, I find that a case example is super helpful so we can understand how it practically looks in clinic and neuropsychology's role in that. So I'll be talking about James. He's a 9-year-old. Also, none of this is real names or anything, all de-identified. So no worries there. He is a 9-year-old left-handed white English-speaking male. He was born full term after an uncomplicated pregnancy, and he was a healthy birth weight. For early development, he received early intervention through Babies Can't Wait, which is Georgia's early intervention services for a speech delay, and no other delays were reported. For his academics, at this time, he was in the 3rd grade, and he had an IEP under emotional behavioral dysregulation and speech and language impairment. He was in a regular education setting, and he had ongoing delays in all of his academic subjects. I will say there was unclear reporting around the services received and just how delayed he might be academically. In terms of family, education, and psychosocial information, this patient lives with his mother and older siblings in Georgia. His parents received their a high school degree. He has a family history of mood disruption, depression, anxiety, and for psychosocial concerns, his mother reported concerns regarding anxiety. For James' medical history, he has a medical history noteworthy for tuberosclerosis complex with a mutation on the TSC2 gene. Epilepsy was the primary functionally impairing symptom of his tuberosclerosis complex, for which he was prescribed trileptal, Depakote, Topamax, and Afinitor. Additional concerns noted were related to nocturnal enuresis, bowel incontinence, and sleep. So I just wanted to, I know this talk is not about tuberosclerosis, but I wanted to take a minute to orient you all to tuberosclerosis complex if this is something that you might be unfamiliar with. It's an autosomal dominant genetic disorder with mutations in the TSC1 or TSC2 gene, which code for the production of a protein called tuberin. This protein is in charge of cell growth, and the mutation leads to proliferation of this growth, which leads to growth of non-cancerous tumors across organ systems, which can, of course, be problematic if there is something there that shouldn't be there. And there's also the tuberosclerosis complex associated neuropsychiatric disorders, which includes behavioral, psychiatric, intellectual, academic, psychosocial, and neuropsychological challenges more broadly. This profile can be highly variable across patients with TSC. And in this figure, you can see some things that you might expect across your patients with tuberosclerosis. For this patient's tuberosclerosis symptoms, he had the classic dermatological symptoms. He had cardiac symptoms, including history of rhabdomyomas or like growths near the heart. He had aspects of that psychiatric profile with anxiety, developmental delays, and an atypical neuropsychological profile. And in terms of neurologic implications, he has epilepsy with many tubers or growths in the brain, which we'll talk about further moving forward. So for James's pre-surgical workup, his seizures began around the 4 weeks of age. Parents noticed muscle spasms where his arm was bent and jerked, which would last for seconds to minutes and occurred multiple times per day. This eventually led to an MRI where he was diagnosed with tuberosclerosis. Now, at the time that we saw him, he has seizures multiple times a week, with bad weeks having seizures 2 to 3 times per day. He was previously a surgical candidate, but he didn't go through surgery as the semiology appeared inconsistent. At this time, as he's continued to fail medication, they're trying a surgical workup again. So for his primary seizure types, type A, which is primary seizure, which involves his head dropping, his arms stiffening, and his eyes closing. He doesn't have an aura. His seizures were triggered by heat, stress, loud noises, or like being startled. And these seizures happen frequently, several times per week, and last 1 to 3 minutes. He also had 2 other types of seizures, which consisted of his eyes deviating to the right, his leg extending, and his jaw stiffening. These last for 1 to 3 minutes, and they're rare. And the last seizure type consisted of his right arm twitching and facial movements, and they are also rare. And the epilepsy team that said that this suggests a left-sided lateralization with localization in the S1, M1 posterior quadrant, temporal or precuneus areas. So as part of his pre-surgical workup, he spent 5 days in the EMU, which was very successful. They captured 13 electroclinical seizures, which for all of you that do this work, that is not always the case. So we actually got a lot of data this time. And multiple subclinical seizures, which all originated from the left hemisphere. I did want to point out that there are some inconsistencies in findings with evidence of atypical, like right-sided discharges. So based off of this information, we were able to update the lateralization and localization, being left greater than right lateralization, but right, might play some sort of role here with the localization of like central to frontal. Before we saw James as part of neuropsychology, he also had an MRI and a PET scan. And you can see the large cortical and subcortical tubers, particularly on the left frontal lobe. I don't know if you can see my mouse, but I mean, I like this as a training case because even non-neurologists or radiologists can see some of the differences here. So you can see the large cortical and subcortical tuber on the left frontal lobe, and on the PET scan, you can see multiple areas of hypometabolism associated with known cortical and subcortical tubers. The largest areas without associated calcification are in the posterior left frontal lobe near the vertex and in the lateral left parietal occipital region. Large areas of hypermetabolism are present in association with the calcified tubers, notably in the left middle frontal gyrus, high right parietal lobe, and right parietal occipital lobe. Okay. And with that, they were able to update, again, the lateralization and localization to those specific regions discussed. As you can see, it's primarily left hemisphere in that precentral sulcus, postcentral gyrus region. So kind of that frontal parietal region of the brain. So this patient was seen in our department in 2019 for the first time when he was 6 years old. And I'm not going to talk through the entire evaluation, but I did want to highlight some potential emerging areas of concern with some areas of strength as well. So overall, his data was pretty scattered, but it shows some early hints towards lateralization and frontal dysfunction with expressive versus receptive language skills, left versus right fine motor skills, and executive dysfunction. At this time, he was also showing some emotional and behavioral dysregulation, and ultimately left the evaluation with diagnoses of a neurodevelopmental disorder, language disorder, and speech sound disorder. We saw him again a couple years ago when he was 9 during the pre-surgical workup. And at this time, I know it's probably difficult to hold all of the information from the last evaluation in your head, but you can see a lot of his scores during this evaluation were, broadly average with some weaknesses in language and academics. And during this next evaluation, there are areas in which he's certainly having greater difficulty keeping pace with his peers and perhaps growing into some of his deficits, particularly related to the fine motor skills and some of the expressive language pieces. His academics continue to be an area of weakness as well. And so, although these results aren't strongly lateralizing or localizing, you can see hints of it with the expressive language and right hand weakness. But overall, some scatter with good strengths and weaknesses. As part of our evaluation, we got parent report. And from that, we found that they were reporting difficulties with emotional and cognitive regulation, clinically significant or at-risk concerns for behavioral symptoms, and variable activities of daily living. And our behavioral observations captured some key things to note, including articulation difficulties, which often impacted intelligibility, and adequate graphomotor control using his left hand. There was evidence of anxiety, but at this time there wasn't strong evidence of behavioral or emotional dysregulation more broadly. At this time, we diagnosed him with a neurodevelopmental disorder, language disorder, specific learning disability with impairment in reading, specific learning disability with impairment in math, and we recommended that he continue his IEP services, receive additional speech language therapy, and be referred for an fMRI and SEEG if they were to move forward with surgical planning, which is what happened. So following this patient came in for an fMRI so we could better understand his brain functioning. I know we're probably all familiar with fMRI, but I wanted to highlight that this is a functional form of neuroimaging, which shows neural activation in the context of certain paradigms, which really helps us to inform the lateralization of certain skills. This is not an MRI or PET, which helps more with the localization of lesions. So as part of his fMRI, we did 2 language tasks, which was auditory discrimination and stories, as well as a motor paradigm of finger tapping. So with this, the results showed activation in the left frontal operculum for the auditory discrimination task, and activation on the contralateral primary motor strips for each hand. So it did indicate a left-sided language dominance, as well as an organization of motor functioning that we would expect. So with this, James came in for an SEEG, as Dr. Bearden had described to all of us the process for that earlier. And so before they do the implantation, the epilepsy team gets together and they create their hypotheses for where the seizures might be coming from. So these were the 3 hypotheses for the location of the seizure focus based on all of the workup done so far for his pre-surgical workup. And so you can see the hypotheses center around the left posterior region of the frontal lobe, as well as the primary seizure focus. And so here I just wanted to pull it all together so you can see all of the different things that we did as part of the pre-surgical workup and how that informed the team's hypotheses. So for the SEEG, they were able to then make a map based on those hypotheses with key regions of the brain to target. And you can see the electrodes. They're all the letters that you can hopefully see on the left and right side here. And this map has different colors because yellow are the calcified tubers, and then there are other non-calcified tubers in blue. And the chart on the right shows where the depth electrodes are and where the stimulation occurs. So as Dr. Bearden mentioned, you would go through the electrodes for the stimulation, as well as each electrode contact 1 through 10, which then passes through different areas of the brain depending on its depth. And so as a neuropsychology team, after we get this map, what we do is we look at where all of the electrodes are implanted, and then we go back to our knowledge of brain behavior relationships and pick tasks that we think would best capture the function of that region of the brain. As Dr. Bearden mentioned, this is not a standardized activity yet. And these skills are also highly dependent on the patient's skill level as well as where the electrodes are placed. But I wanted to give an example here of this patient's electrodes and the tasks that we chose. And again, I like this patient as a training case because he has a very left-sided motor language heavy map, which I think maps really nicely onto our knowledge of brain behavior functions as neuropsychologists and trainees in neuropsychology. So I'm not going to talk through all the results for all of the electrodes in the interest of time, but I'll focus on the location around the tuber in yellow, which is presumed to associate with the seizure focus. Sorry, by tuber in yellow, I mean this area right here. And so during the stimulation, we're able to use our skills as neuropsychologists in terms of task selection, how we administer tasks, and behavioral observations to make clinical judgments, which can inform the knowledge of what may or may not be eloquent cortex. So when we stimulated electrode A, you can see here that we kind of stimulated Broca's area. For this, we decided to do reading, and we saw a speech delay. And so this shows us that this area might be impacting this patient's ability to speak. When we stimulated electrode B, we saw facial grimacing. When we stimulated C, we did digit span, forward, reading, and during that, we also saw another speech delay. And when we stimulated electrode D, we saw motor disruptions, and ultimately a seizure was triggered. So again, these we all thought to be very impactful areas with potential surgical risk. So if they were to go to do surgery to remove this tuber, we were concerned about a risk for aphasia and right motor weakness. And so for surgical planning, we found that results suggest James' epileptogenic network organizes to involve electrode D and B in the SMA, superior frontal gyrus, mid-cingulate, and precentral sulcus. And that is all in the purple circle here. And then it spreads out further into this green circle. So the team recommended resection of that yellow tuber in between electrodes B and C and superiorly to involve electrode D. So basically that whole purple circle there. And so, as I mentioned earlier, with risks, expressive aphasia, right-sided motor weakness. And then I was lucky enough to be able to see this patient post-operatively. And so this patient did have the surgery where they resected a good portion of his left frontal lobe. There were no surgical complications. And this case was actually maybe over a year ago at this point, and he still has had no seizures to date. So that is very exciting. Acutely post-operatively, he was having right-sided weaknesses and expressive language difficulties. And I saw James on our inpatient rehabilitation unit. And although he performed okay objectively, because I had known him previously, I was able to see how he really did struggle with aspects of expressive language, fluency, articulation, repetition, aspects of word finding, spelling, and those right upper extremity movements. So hopefully we'll see him back shortly for a post-surgical evaluation. And if people follow up with me, I can update you all further. But with that, wanted to see if anybody had any questions, and I appreciate everyone's attention. We saved a lot of time for questions, so hopefully we have some. I'll stop sharing my screen maybe.
Thank you both very much for the presentation. Yes, we have a few questions because it was a very excellent presentation and several people reached out. So we were hoping you could go over just a little bit about what helps determine whether to use SEEG versus subdural electrodes, and are there any cases in particular in which subdural electrodes would be preferred?
That's a great question. So, as I mentioned, here at Children's Healthcare of Atlanta, we've moved away completely from subdural electrodes for safety reasons, because it requires a craniotomy. And research to date shows that using both results in about the same amount of success, essentially, but there's not much out there comparing them. So that's the caveat that's really important. A lot of research needs to be done to make sure they are equivalent. Ideally, if you're looking at language, having dense coverage on the lateral surface for that area would be great, because it's all there, right? So it's not in the deeper structures, it's more on that lateral surface. So when we're looking at language, that's when subdural electrodes would be fantastic. And it would be great to have a mixture, depending on the patient's where we're hypothesizing that the epileptogenic zone is. For some patients, in a perfect world, we would have some mixture of subdural electrodes and SEEG electrodes, but it's just not, it's too risky in most cases. Although there are some, I know I do have colleagues at some institutes around the nation that are doing a mixture, and they're reporting that it's actually going pretty well. But that depends on your neurosurgeon and the comfortability of the team in doing that type of invasive procedure, combining those two methods. So I would say language is great if we're concerned about the dominant hemisphere, and that's where the epileptogenic zone is, and we're worried about damaging that with epilepsy surgery. That would be a great example of when we would want to use subdural electrodes, but we're not, at least here.
Thank you. And so just speaking a little bit more about your guys' experience and your role on that team, we were wondering how as a neuropsychologist you all are involved in evaluating the risk and the benefit. For example, like the case that you presented, choosing that concern around or identifying the concern around aphasia, determining whether this is going to be a good candidate for surgery, and things like that.
Documents.
Sure. Ultimately, we're involved in all of the meetings where they discuss the surgical plan and we present our results. But the surgery team is going to do what they decide to do. And I think it's important to weigh the risk of potential functional changes, like we talked about with aphasia and motor weakness, with the risk of what ongoing uncontrolled seizures might do for their overall cognitive skills. And so neither of those are good things necessarily. And so it is a risk benefit analysis there. And in some cases, our team does decide to go with a more conservative approach. And I think, they will use our data to help support why it might be important to do a more conservative approach or take like a staged approach where we do sometimes, where we'll start with like RF ablation or an RNS, and then see how their seizure control is after that and how they're doing functionally. And if they're not experiencing any functional changes after something like an RF ablation, they might go in and do a further resection after the fact. So we're there every step of the way helping evaluate those risks and outcomes.
And I would add to that, so we are in fact sitting at the bedside testing the patient in those areas. So not typically with RF ablation, we're not doing every electrode, right? So we've done the stereo EEG, we've identified the areas of the electrodes where we think that's the epileptogenic zone, and we may be too concerned that we would cause a functional loss. So we're just pinpointing specific electrodes, and we're doing the language tasks while the neurosurgeon is ablating that area to see if there are any functional changes. And then we monitor them, and we may even do say within 2 weeks, which is general guidelines suggest that within 2 weeks of doing RF ablation is when you want to do your testing. So then we might have them come back in for a brief evaluation of language and compare it to the pre-ablation performance to see if there are any changes. And then if there are changes, that would indicate that we should be very wary of doing a further resection. Now, I will say, I've had a number of patients where they've come in and we've done our testing. We've suggested that probably surgery isn't a good idea, but we go ahead and get them in for SEEG mapping anyway, because that's the last hope, right? And we do in fact see, hey, we're right there mapping. And I have said to my colleagues, yeah, we can't, the risk is too high. This patient has very strong language skills, and that epileptogenic zone is right over the language area. We know that from functional MRI. And so really, it's contraindicated at this point. And they do listen to us, absolutely. And they will make the final decision, but they do weigh heavily our input, which is nice.
That is very nice. So speaking a little bit more about the tools that you all use to help you make some of those decisions and to guide the team. We had one question about whether a WADA still needs to be done if you're doing an fMRI and SEEG, and whether or not a WADA is being used. Are there any other standardized assessments or standard administration that you all use during SEEG testing, or do you focus more on like qualitative observations?
Would you like me to?
Yeah, you can. I guess I'll start with the standard. I'll start with the latter part, and then I'll have Dr. Bearden jump in about the WADA. I will say sometimes we'll do like a WADA basically during an SEEG, those types of tasks. I will also say we have great standardized tools in neuropsychology. They are not super well suited for an SEEG, given particularly the train durations of like how long stimulation occurs for, but we do pull heavily from our tasks for those things. And so if we're looking at something like auditory attention, we will use something like a digit span, or when we do picture naming, looking at their language, we will use stimuli from some of our already validated materials that we then would practice with our patients to see how they're doing at baseline. And so maybe not standardized in the way of like every patient gets the same thing, but we do try to have some level of consistency across these patients.
Thank you, Dr. Winston. And that will further vary based on the patient's age and functional level and bandwidth. So that all those factors have to be considered when we're deciding on the test battery for a child. And it helps. That's one of the reasons I think neuropsychologists are ideally suited for this role, because we have probably spent more time with the patient than anyone else, any other provider. And we have seen the patient under stress during testing. We've talked to parents. We know what the patient can handle generally under optimal conditions. And then we're putting them in a hospital room where they have electrodes in their brain. So all that needs to be considered. And with our clinical psychology background, we are really ideally suited for that role. Now, talking about WADA, it's a good question. So we have to think about what the question is, right? So fMRI is telling us, at least up to this point, really is telling us about language and motor lateralization, all right? It's not really ideally suited for localization. It's really lateralization is what fMRI is mostly is most valid for use for. When we are thinking about a WADA, really at this point, because we've got fMRI that does a great job with language lateralization, research shows that it's equal with WADA. It's a strong tool. So when we're thinking about WADA nowadays, it's really memory, especially in our patients who are high functioning, and they would potentially suffer a significant loss to their learning and memory skill if those hippocampal, parahippocampal, entorhinal areas are at risk for surgical destruction. And our neuropsych measures are indicating that their memory skills are generally intact. fMRI is not, at least to this point, it's not really been validated for memory use in that way. Maybe in the future, but not yet. And so really that WADA, we typically use it to identify where memory lives and whether one hemisphere can manage verbal and or visual memory while the other hemisphere is asleep. And that will then guide surgical planning, as you can imagine.
I also will say our patients are kids. And a lot of them are a little bit lower functioning. And so things like awake craniotomies and WADAs can be very taxing on these kids. And so that makes some of it challenging too.
Sorry, speaking a little bit more about the WADA, have you all had an electric WADA used at your center or any point in your training? And if you have had experience with it, can you speak a little bit about whether it's helpful, not helpful, what the differences and similarities are to traditional WADA testing?
So yes, we actually published a paper on, it's called 4-way WADA. And we had a patient, we did different versions of the WADA test. We did them for stereo EEG. We did an actual WADA on the patient, so a chemical WADA. We did a stereo EEG or electric WADA. And then we did a WADA looking just at, so a non-stimulation WADA, looking at just high frequency activity and cross-frequency coupling. And we compared the activation across those three modalities. And it was very helpful. They all gave us interesting, unique information that helped us to plan for that patient. It was a high functioning patient. And as I said, each of those modalities gave us different information and led to a successful anterior temporal pole resection of the dominant hemisphere and a hippocampal transection. And now 3 or 4 years later, the patient's still seizure free, suffered some, as we might expect, some word finding difficulties still, some very mild learning, verbal learning and memory issues, but nothing that held him back from being successful, completing college, all those types of things. So we're still in the phase of learning more about how we can use stereo EEG as a tool for memory. Same for fMRI, right? But it has been shown. Dr. Drain and colleagues also published at Emory published a paper on electric WADA. I would say, though, as a cautionary point, we don't know yet enough, and the hippocampus, as I mentioned, is very prone to seizures from electrocortical stimulation, even low frequency electrocortical stimulation. It's very susceptible to seizure activity, and we don't fully understand what the consequences, long-term consequences might be of triggering seizures through depth electrodes in the hippocampus, given that it is so seizure prone. So I think right now, I would just say wait until more studies, more data is out before we really go full force on doing electric WADAs.
Okay, and I know we are just at time, but we have one more quick question. Have you found any helpful memory paradigms in SEEG?
We do lists often with SEEG where we'll present them the list right before a stimulation, let the stimulation run, and have them recall it after the fact to see if the stimulation disrupted the encoding of the information being presented to them. And we find that to be like a quick and helpful task and paradigm. We also have like a visual version of that where we'll like hold up a shape again beforehand, wait, and then show them like an array, and they have to pick from the array which one we had shown them previously.
Yep, that's what we're doing. And we try and gauge it by, again, patient's age, functional level. There's a lot going on in the room while we're mapping. You know, can they really attend to a list of words? The list of words will vary depending on whether we're doing high frequency or low frequency, because we have more or less time. But even when we have a lot of time, that's 15 seconds.
Right.
So it's barely enough time to get like a CBLT. And then the idea that we would do that multiple times for each trial, it's just maybe under certain circumstances, but in general, the patient doesn't have the bandwidth for that.
And this is where baseline mapping is really important too, so we can get a good sense of what the patient can handle from a memory perspective before we work with them during mapping.
That makes sense. Well, I want to respect everybody's time. I know we're at the top of the hour, and thank you all very much for this presentation. Just from the sheer number of questions, you can tell it was a very engaged audience. We were all very, very interested. So please join us again. Actually, tomorrow we have a makeup lecture, Creativity in Awake Craniotomy, a Patient-Centric Approach by Dr. Heidi Bender. And then again in 2 weeks, we're taking next week off for the holiday. And that will be Neuropsychology in Congenital Heart Disease by Dr. Bruna Schneider. All right. So thank you all very much for joining us today. And we look forward to seeing you again, hopefully tomorrow, and if not, in 2 weeks. Thank you.